Today's webinar is titled Getting Anaphylaxis Right, presented by Jeffrey Anderson. I'm going to pass it over now to our presenter. Jeff, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you. So the title of the presentation, Getting Anaphylaxis Right, came from an article that I read several months ago on Facebook. And this is the actual published journal article. It was published a couple weeks ago, but it was reported from the conference of the Annals of Allergy, Asthma, and Immunology. It was an abstract of the immunology conference where an immunologist and a couple other people decided to study how EMS identified and treated anaphylaxis. So they gathered a bunch of protocols from state that had statewide protocols, and they studied how we identified anaphylaxis, how we treated it, identified some recommendations. And so that's going to be a big part of what we're going to talk about today. I'll get more in depth on the paper in a minute, but the take-home points today, number one, the eye cannot see what the mind doesn't know. So that's a common EMS phrase, but in this case, it's talking about our knowledge of anaphylaxis and how it can present and how to identify actual anaphylaxis versus allergic reaction. The second take-home point is that IM epinephrine is the primary treatment for anaphylaxis. The third take-home point is that IM epinephrine is safe. And then the fourth is that EMS initial education programs can help change the way our profession treats anaphylaxis. So first of all, the eye cannot see what the mind does not know. So my journey with anaphylaxis started with this young man right here. He's 16 now, looks a little bit different, has a lot more attitude, but he was born where he would wheeze. He had uh, skin problems, the classic asthma allergy scenario. And then when he was about 2 years old, we took him to a steakhouse and he jumped on the floor and got into some of the peanuts and then just came back just beet red, urticaria everywhere. Then a couple of days later, he ate some cereal with peanuts in it, some Reese's peanut butter cereal, and threw it up immediately. And so right away, I'm thinking, wow, we got a problem. We need to get him tested. Come to find out, he is allergic to peanuts, milk, eggs, and we got the EpiPens, the whole 9 yards. Thankfully, we never had to use the EpiPens. But the reason why I wanted to bring this up is when the allergist diagnosed him and gave us the EpiPens and provided us training on them, she said that if he had a reaction that involved two body systems, we were to give him the epinephrine. And that really struck me as a paramedic of about 10 years at that point. That was a much lower threshold for giving epinephrine than was previously accustomed to. My protocols were a little bit stricter. They wanted more severity in the reaction before we gave the epinephrine. And I was concerned because I thought, epinephrine's a pretty potent drug. There's serious consequences to giving it. And so I had to study a little bit more, and she guided us a little bit more. And that kind of speaks to the purpose of the paper that we just referenced that we're going to talk about in a minute. Thankfully, I've never had to actually give Jackson his EpiPen. He also has asthma, and we've given him lots of breathing treatments and had issues with that, but never allergic reactions or anaphylaxis, thankfully. So getting back to the paper, it was written by two immunologists, one emergency physician, and a medical student. So what they did was they gathered statewide, either mandated or model protocols. So they were left with about 30 because a lot of states don't have statewide protocols. And they analyzed them for gaps in recognizing anaphylaxis and treating anaphylaxis. So, like I said, they had 30 statewide protocols that were included. 15 included GI symptoms in the definition of anaphylaxis. So that's one of the things that kind of struck me was we don't really talk about that in EMS as much, or at least we haven't in the past. Things are probably starting to change a bit. Only 14 of the protocols used the two system definition. 30 recommended diphenhydramine and epinephrine, so we did good there. 27 recommended albuterol with respiratory symptoms. 29 listed epinephrine as first line, and then 25 allowed for auto injectors. So their recommendations, number one, was that many of the protocols in the study were incomplete or outdated. I think most of them were for 2020 or before. Uh, they recommended that we expand our definition of anaphylaxis to include the two-system definition. Uh, they recommended continuing to emphasize IM epinephrine as first line and to broaden the use of epinephrine autoinjectors. One of the concerns they identified was we have traditionally given epinephrine with a syringe and an ampule as paramedics and advanced EMTs and intermediates, but what happens if there's not an advanced EMT or a paramedic on board the truck? What if it's EMT only? Which in a lot of areas of the country we have that. And so are the ambulances equipped with epinephrine auto injectors? Are they available for use? I know in Louisiana we had this conversation over 10 years ago about taking epinephrine auto injectors from a patient assist medication for EMTs to a you can carry it and give it medication because there are ambulance services in Louisiana that are BLS, in addition to fire first response and other situations. So epinephrine auto injectors are a big issue for the allergist because they provide a safe, reliable dosing. They are more expensive though, and the paper did discuss that. But you're even seeing epinephrine auto injectors on ALS units. You're seeing them in ERs now just because they're so easy to use and they're safe. Uh, Another thing that they listed is EMS should transition to generation antihistamines because of the side effect profile of diphenhydramine. Their recommendation was sertrazine, and they also kind of threw a bit of a curveball in there when they talked about how IV sertrazine can be very expensive, but there's really no reason why these patients can't get PO. So, given the safety side effect and the side effects, not so much safety, but just the side effects, the drowsiness and other things that come from diphenhydramine, they wanting us to transition to second generation antihistamines. And then the other point that I thought was interesting is they said that we should not be giving steroids in anaphylaxis, glucocorticoids like Solumedrol. I did not see that one coming, but their argument was that the side effects of steroids far outweigh the benefits of the steroids. And one issue that corresponds with this is the allergists are putting a lot less emphasis on biphasic reactions than we have in the past. They're not as concerned about that as maybe we've been. And so their argument is that we just don't have a good reason to give steroids that counteracts the side effects of giving the steroids and how long they take to work and everything else. So I thought that was kind of interesting. But those are the things they were looking for in the paper, in the statewide protocols to see where we were at. Now, obviously, this paper has some limitations. I was a little irked to begin with that they only studied 30 states, state mandated protocols, because in my experience, usually state mandated protocols tend to be a little on the lower side of aggressiveness, and they tend to be more broad, more inclusive of services that aren't as aggressive. Whereas some services are going to be much more aggressive than state protocols if they're allowed to be. And then, in states where there are no protocols, obviously there's a pretty wide variation. So I could see for simplicity's sake why they chose to do it this way, but I'm not sure they got an accurate picture of EMS and anaphylaxis. But it's still, I think it was a good paper overall, and it raised some great questions. And then we as educators, we're part of the solution to this. So another paper that I wanted to bring up that I think is very important when it goes back to understanding what we see and having our knowledge base there so that when we see a patient with a particular problem, we'll recognize it. Uh, there's lots of different guidelines and there's lots of literature out there about anaphylaxis, but I think one of the ones we should all be familiar with is the guidance from the World Allergy Organization. So this would be similar to the AHA guidelines, maybe not quite as rigorous, but this has been worked on and endorsed by over 51 organizations from around the world. So the only thing that's going to be better is if there's ever any intergalactic anaphylaxis guidelines. But they have some pretty good recommendations in here, and it's a good background that we could all benefit from when we're teaching anaphylaxis. So their definition is anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid at onset and may cause death. Severe anaphylaxis is characterized by potential life-threatening compromise in airway, breathing, and/or circulation, and may occur without typical skin features or circulatory shock being present. But that's, that's not very controversial definition there, but where I really like it is when they get to more specific about what constitutes anaphylaxis. So this came from the guidelines. And so their definition is anaphylaxis is highly likely when one of the following two criteria is fulfilled. So you have an acute onset of illness of several minutes to several hours. A lot of us wouldn't consider hours acute, but in the broader healthcare scheme of things, that is acute. Uh, with involvement of the skin, mucosal tissue, or both. And then they could have airway breathing, respiratory compromise. There could be circulatory compromise, reduced blood pressure, and organ dysfunction, or severe GI symptoms. And as the paper pointed out, we don't talk as much about severe GI symptoms as the allergists do. So adding that to our the way we teach this, I think would be very important. But going back to the paper, this is the two body systems. So this threshold is going to be lower than a lot of us have had in our protocols, maybe even today, and a lot lower than is in some of our textbooks. And that's what I found when I was discussing this with my son's allergist, is their threshold for epinephrine and for diagnosing anaphylaxis has been lower than ours. Another issue is you've got the typical presentation of anaphylaxis versus the atypical. And one of the atypical presentations that research has shown we're not as good at recognizing is when you just have a sudden onset of hypotension, especially in cases where you have IV med administration. Somebody gets exposed to something they react to fairly quickly, and all of a sudden they have a cardiovascular collapse. Do we recognize that as an anaphylaxis? And then you could have also sudden onset of bronchospasm or laryngeal involvement. So again, just the definition is a little bit broader than we're used to in standard EMS practice. I took this from the National Model EMS Clinical Guidelines, which I love this document so much. It's a really good guide. I recommend it to students as a study guide too, but they don't seem to do too bad. Their definition of anaphylaxis, more severe than an allergic reaction, acute onset, you've got skin or mucosa, respiratory compromise, decreased blood pressure, hypotension, or two or more of the following occurring rapidly after exposure to a likely allergen. So skin and mucosal involvement, respiratory compromise, GI symptoms, hypotension. And they also include non-anaphylactic reactions where you have a not necessarily IgE mediated or a specific reaction to a substance. And there's other things that look like anaphylaxis that don't even involve the immune system, like ACE inhibitor-induced angioedema and things like that. But that's a little bit beyond our discussion today. So anyway, the National Model EMS Clinical Guidelines have a pretty good definition, and I would love to ask the authors, have they seen these and what they think about it? So that's the knowledge base. So the knowledge, the question of knowledge for us is just, is our curriculum teaching the current thinking and guidelines from anaphylaxis? Are we gone beyond what we maybe have done in the past? And that was a big wake up for me, realizing that I probably was not covering this adequately, and it's a potentially life-threatening emergency. So the next question is, how do we treat it? And so the allergists, the emergency medicine, we all are consistently saying that IM epinephrine is the primary treatment for anaphylaxis. So this again comes from the World Allergy Guidelines. So they recommend to have a written emergency protocol for treatment anaphylaxis, remove the exposure to the trigger if that's possible, assess airway breathing, circulation, all of that, call for help if you're not in a situation where help's already there, and then inject epinephrine intramuscularly into the mid-anterolateral aspect of the thigh. This is still a big issue for us. We've been talking for years about intramuscular epinephrine, but I still see test questions. I still see textbooks, articles refer to subcutaneous epinephrine. In all of my research to prepare for this presentation, nowhere did I see subcutaneous epinephrine be recommended. It's the only recommendation is intramuscular. And that's what EpiPens provide, is intramuscular epinephrine. So, but even today, I see test questions and other things where we're still talking about sub-Q, and that's just not recommended anymore. We need to be teaching IM only, or IV, which we'll talk about in a minute. Placing the patient on their back, that's another issue. If you have profound vasodilation, they're starting to get a little shocky. Placing them on their back is going to help them with their perfusion, unless, of course, they can't lay flat because they're having trouble breathing or what have you. Supplemental oxygen. Uh, Going back to the EpiPens, we talked about those a minute ago. That's a big push, is to make sure that everybody has access to at least EpiPens, if not, regular epinephrine. There's different kinds of EpiPens now. They are getting a little cheaper. There's generic versions. So the next part of the guidelines, and one of the issues that the authors in the original article raised, was about supportive care afterwards. Just because we give the patient epinephrine doesn't mean they may not need fluid. And so giving a certain amount of IV fluid to support their blood pressure after the epinephrine is also a good idea. And then if things do deteriorate to the point where they need CPR, obviously we would work a cardiac arrest like we always would. Reassessment is another big one because their blood pressure can change, the epinephrine can wear off. We just need to reassess them periodically to look for changes. So here's the page from the Model EMS guidelines, which pretty much go along with this. One of the things they mention is an epinephrine drip, which wasn't as common. I wasn't really familiar with how to give IV epi in a severe anaphylaxis when I was younger. We've talked a lot more about that in the last 10 years. It's in these guidelines. It's been in other guidelines too. You'll notice that the guidelines still call for diphenhydramine. I still think that's going to be pretty much the common experience around here. I'm not sure how much of in a hurry we are to change that. Also, it mentions H2 blockers. You'll see that in the hospital a lot. But for my reading of the literature, they don't tend to add much benefit past an H1 blocker. So I don't see a lot of EMS agencies carrying those or giving them. But I'm sure there's some out there that do. So the next point that I wanted to make is that epinephrine is safe. This goes back to the two core issues I think that we're dealing with when it comes to anaphylaxis. Number one, recognizing that this is anaphylaxis, which I think the two body system rule and the other guidance we've talked about really helps with that. But also, we have a fear of epinephrine because we know it's a potent drug. We know that it can be dangerous. And so we're afraid that if we give it unnecessarily, we're going to cause harm. And I think that's one of the things that the allergy community, the immunology community has really been pushing, is the fact that IM epinephrine is safe. This is an example of an article that I found talking about this. They did an observational study with 277 cases where epinephrine was administered for suspected anaphylaxis. 58 reported side effects such as tremors, palpitations, anxiety. 8 reported chest pain, elevated blood pressure, or ECG changes. None of them were permanent. None of them deteriorated to anything severe. Uh, One thing that I found interesting in this paper was the side effects kind of happened across the entire cohort. It wasn't limited to older people or somebody you would suspect. And so the authors concluded that restricting IM epinephrine in anaphylaxis due to potential adverse effects was not justified. There was a study from 2012 where they were evaluating paramedics' knowledge of anaphylaxis, and they had the paramedics list the side effects or contraindications, my apologies, contraindications to epinephrine in anaphylaxis. And this is the list that they came up with: coronary artery disease, an allergy to epinephrine, tachycardia, including any kind of dysrhythmias, SVT, older age, hypertension, shock, pregnancy, glaucoma. These are the perceived contraindications, but again, the authors reiterated there is no contraindication for IM epinephrine in anaphylaxis. It's safe, it's effective, and we're not going to harm people by giving it. And so I think there's two issues with this statement. Number one, understanding that it's safe, but I go back to the idea that we still struggle with identifying anaphylaxis, which I think is the core issue for us. Any paramedic's going to say, yeah, you give epinephrine for anaphylaxis, but when you pin them down on what anaphylaxis actually looks like and can they identify it, when it's a classic case, yeah, they do a fairly good job at that. But when there's an atypical presentation like sudden cardiovascular collapse or something along those lines, they may miss it. And so also we tend to have a much higher threshold for giving epinephrine than the allergist maybe would like. So just understanding these two things, I think, is very important. Now, IV epinephrine may be necessary, but it also could be harmful if given incorrectly. Most of us have probably heard a story of someone giving a cardiac arrest dose of IV epinephrine in a patient with anaphylaxis, and obviously that can lead to some pretty serious side effects. But there's several different strategies out there for giving IV epinephrine. A couple that I'm familiar with and have used in the past is the push dose epi, where you take 1 milliliter of cardiac epinephrine, mix it with 9 mils of saline. Now you've got 10 micrograms per milliliter. And then you give 1 mil at a time until you get a resolution of symptoms or you get the result you're looking for. So instead of giving 1,000 micrograms of epinephrine in a bolus, we're giving 10 micrograms at a time, a much more diluted dose. Because again, we know that epinephrine is a potent drug. Another strategy is to mix 1 milligram of epinephrine into a liter of saline and then start infusing 1 milliliter per minute and then doubling that dose, titrating it upward until you get the result you're looking for. That would be better with a pump, obviously, but we don't always carry pumps. And so this is still something you can do reasonably safely. Again, it's a very diluted amount of epinephrine. And this is very similar to how we would treat any other distributive shock. We give them a little bit of fluid and then we give them a pressor. So my last point, which I've gotten to a little bit quicker than I had intended, EMS education programs can help change the way our profession treats anaphylaxis. So some things we can do. Number one is just increase the knowledge base of the faculty and make sure our curriculum covers the latest evidence-based guidelines and current literature. And then there's a lot out there, not all of it produced by EMS, but produced by the immunology community, by the emergency medicine community. There's other stuff out there that we can incorporate into our curriculum. We've also got the NAEMSE guidelines, which provide a pretty good reference. But just make sure that we're broadening our horizons and looking for all the relevant information to put into the curriculum so that we're teaching this accurately. The second thing is make sure everybody is on board. I've discovered this in a couple of different scenarios where I wrote scenarios for anaphylaxis in our lab. And one of them in particular, I wrote an EMT level scenario where the patient had urticaria and GI symptoms from eating a sandwich that had something they were allergic to in it. And I got a lot of pushback from my EMT faculty saying, well, that's not anaphylaxis. And so we had to do some continuing education amongst ourselves to make sure that everybody was on the same page with what actually constituted anaphylaxis. Because the argument wasn't we give epinephrine anaphylaxis. The argument was, well, that wasn't anaphylaxis. And so once we had that education and we had that discussion, I provided some resources, then we were able to use that scenario and it worked out well. So that's just one example of several that I've had related to that. Just making sure that everybody's on the same page with what we're trying to do with the scenario and what the correct information related to that scenario is. The next thing we should be thinking about is our formative assessments, whether it's didactic formative assessments in the classroom or in our LMS or in the lab, the scenarios we use to train the students in the lab with. Are we just giving the typical presentation of anaphylaxis, or are we branching out to atypical presentations of anaphylaxis that would challenge them a little bit more? The World Allergy Guidelines have several different presentations of anaphylaxis. You could take that and write a scenario based on each one and have a variety. So if you're doing a set of scenarios in a lab with a group of students, everybody can have their own. It's a little bit different. And they're all reinforcing the different ways that anaphylaxis could present. And so that will reinforce what you've already taught them, which would be very important. The other thing is present the material in a way that it will be used. Sometimes we teach the different topics in kind of a sterile, isolated way from each other. And one of the things I think is important in teaching students how to recognize anaphylaxis is to teach it in a way that they're going to see it in the field. And one of the ways that we do this is I have a lesson on angioedema, and we cover anaphylaxis as a part of that, in addition to teaching it as a part of respiratory distress and a distributive shock. So there's several different places they're being exposed to the material, and we're putting it in context with how it would present in the field. So they're starting with the patient presentation and a little bit of history, and then they're working themselves out to the answer and then to the appropriate treatment. So I think that's very important is we don't just teach the isolated concept knowledge, but we teach how it's going to be used, how you would get to the point where you would use that information, and then obviously how you would manage those patients. So that is the basically the one I wanted to cover today. I that went through it a lot faster than I thought. I hope you'll have some questions. I'd love to discuss this with you. But just to reiterate, knowledge is a big part of this problem. We can't see what we don't know. So teaching anaphylaxis in a way that people are going to be able to use the information and giving them a complete picture of anaphylaxis is going to be very important. IM epinephrine is the primary treatment for anaphylaxis, and we don't need to be scared of epinephrine because it's safe. And then we have a large role in EMS initial education in treating or teaching our students how to manage these patients appropriately. And with that, any questions? Anything you want to bring up? Anything I should have discussed better? Sure. The scenarios. One of this is a fun favorite topic of mine is the scenarios that we use. I wrote one years ago. Some of y'all were around when the registry transitioned to the out of hospital scenario station. Well, they had rollout workshops, and one of the workshops I went to was in San Antonio, and I had to write a scenario for that. And I was just learning about IV epinephrine and anaphylaxis when I was writing my scenario. So what I did was I wrote a scenario about an anaphylactoid reaction to IV contrast dye at an outpatient radiology facility. Had a young lady was having some abdominal pain. Her primary care doctor ordered a CT of her abdomen with contrast. So the scenario was they go to the place, gets the contrast, she passes out, hypotensive, unresponsive. Wanted the students to handle that. The teaching purpose of the scenario was to see if they would recognize that IM epinephrine was not adequate because of her blood pressure and her perfusion, and would they switch to IV? This is something we taught in our program. And we ran 6 groups through that scenario, and not one single group recognized that it was an anaphylactoid reaction. There was all kinds of other things that they were thinking, but just no one ever got to, hey, this is hypersensitivity, this is anaphylaxis, let's give them epinephrine. And so that got me to thinking. And now we run that scenario with every one of our groups, and we still get a lot of groups miss it and they fail on it. We call it our Kobayashi Maru scenario because it's almost like a no-win situation. But the point isn't to embarrass the students or to do anything like that. It just creates a great discussion afterwards. Here's what you missed. And so here's why you would recognize that. And so that's one scenario. We wrote the scenario with the GI symptoms and the student who was eating a sandwich that a friend had given him, and he developed GI symptoms and had anaphylaxis. That was a good one too, because a lot of our students missed that also. The GI symptom just wasn't enough for them. The fact that the person threw up and their guts were churning, well, that wasn't enough for them to give epinephrine. So those are 2 that we've used. We've used bee sting scenarios. That's more of a classic, sign or symptom of anaphylaxis. So we've just tried to think about what we've seen in the past as clinicians, and then what are some of the ways that it presents, and how can we incorporate that into the curriculum. And again, I've mentioned this on other webinars. One of the things I think is important is these complicated scenarios, these atypical scenarios, do them often, but they don't have to count for a lot of points. So I wouldn't have given that Kobayashi Maru scenario as a final in my program, but it's great for them to see it and to spark discussion of the topic. And then when we do scenarios like that in our program, one of the things I tell them at the very beginning is, look, no one's failing today. We're not grading you today. Our entire purpose is formative. We're trying to give you feedback and trying to have you experience something that they'll remember. And we've had students come back to us and say that, yeah, that did help them remember. What's funny to me is the most common thing I hear about anaphylaxis from my students is they remembered the story I told about my son and learning about the two body systems. And that's what they remembered more than anything else about anaphylaxis was two body systems. And like, well, hey, it's not necessarily a bad thing. And again, that's something I had to learn that I didn't know on my own. So that was a great question. Does anybody else have a good scenario they've used for anaphylaxis that's been good for the students?